So we're going to go through pathology of the kidney. So it's good to look at the normal, go through that PowerPoint that I didn't record, just so you have a normal view of the normal anatomy. And there's multiple pictures of this same picture, basically, normal glomerulus, right? So note the glomerular space or the Bowman space, nice fenestrations, clean, delicate looking cells, epithelial and mesangial nuclei. You don't have to name those. This is just, all you have to call this is a glomerulus and know where the space is. And know what a glomerulus is. So some of the diseases, usually you have something like this first though, glomerulosclerosis, which is hardening or thickening of the glomerulus. So you can't filter blood when you have this situation. So this can come from long-term irritations like diabetes mellitus, hypertension, ongoing, untreated, right? So if you have something like this, sclerosis, and we'll see what it looks like for lab, you could have inflammation of the nephron, and that's glomerulonephritis. So you know the difference terminology-wise. So this is an immune response to something else that's going on, like glomerulosclerosis or infection as well. So glomerulonephritis is inflammation of the glomerulus, which could be from another problem like glomerulosclerosis. So this can be scar tissue, thickening or hardening of the basement membrane of these endothelial cells of the capillaries, which is the glomerulus. This is a pretty good picture of a glomerulosclerosis. Notice you don't have that fenestration, right? You don't see clear spaces between these cells and endothelium. Thickening, right? Capillary basement membrane. This is normal, right? This is a really good one. I mean, it's a really bad one, but it's a good example of glomerulosclerosis at that magnification, right? That histology. This also is glomerulosclerosis. Note that difference. Very simple when you have this nice picture, right? Now, this is acute pyelonephritis, basically a kidney infection. When you hear pyelonephritis, it's a kidney infection. So you're going to see, of course, possibly the actual bacteria developing in this histology. You're going to see abscess, which is basically neutrophils. Like remember we did pneumonia with PMNs. So with pyelonephritis, which is an infection of the kidney, and it doesn't even affect the glomerulus. This is more the tubules. Okay, so think about an infection, right? That's the bacteria is coming from outside the body most of the time, right? Into the urethra, or especially in females because they have a shorter urethra than males. One of the reasons, right? So if you have an infection of the membranes of the lumen of the urethra, you'll have urethritis, right? Which could be very uncomfortable for male or female, right? But females shorter, so it tends to go more upward, right, into the bladder. And an infection of the bladder is called cystitis because the bladder is a bag of fluid and a cyst is a bag of fluid. So an infection of the urethra is urethritis, and an infection of the bladder is cystitis. So what are those conduits above the
You just want to keep one on and one
bladder? What are the two conduits that bring urine into the bladder?
ureter.
Yeah, ureters. So you could have ureteritis. And now what's after that? Where are the ureters coming from? From the kidney, yeah. So that would be pyelonephritis, is the kidney infection. So this it started out as an infection in the urethra from the skin, or also the anal canal, which has E. coli, right? It's completely normal in the anus of the colon, but not normal in the urethra. It's going to cause an infection and an immune response. So this is basically a what? A UTI, a urinary tract infection that can go from the urethra all the way to the nephrons, the parenchyma of the kidney. So a lot of this is PMNs, a lot of neutrophils throughout this tubular area, right? And this is normal up here. These are blood vessels in the middle. These are great glomeruli surrounded by tubules. Remember, the glomerulus or glomeruli are in the cortex, the renal cortex. More of the same. Again, the glomerulus is okay. It's the tubules, because remember, the tubules is where the filtrate is. So, and the lumens of the ureter, of course, is urine, but the tubules is filtrate. So the bacteria is making its way up into the tubules. And if this becomes even worse, of course, you're going to see a chronic pyelonephritis, which is massive amounts of bacteria, number one, and then you also have massive amounts of immune response, like neutrophils. Neutrophils, if you remember, are designed to attack bacteria. So this is a bacterial infection, pyelonephritis, right? Still acute. So same thing, more of the same. Okay, a lot of PMNs infiltrating this tubular area and interstitial area. This is a gross anatomy of a kidney with abscesses. It's not cancer. How do I know? You don't know until you biopsy that tissue, right? But you know the history. Like, this is going to give you a little bit of a case study here. Someone who has flank pain, which is, you know, pain, retroperitoneal pain, like your back pain along the sides, the flank. Feel a little sick. I mean, UTIs will knock you down. They even cause some mild cognitive impairment. MCIs, mild cognitive impairment. This is so draining on the body, a UTI. So when you're nursing, when you're in the nursing unit, especially in like a nursing home or with geriatric, because they're using diapers a lot, right? They're urinating. Some of them are catheterized. They're a little bit more likely to have an infection, right? And sometimes you don't know why. All of a sudden they're in delirium, right? So we'll talk about the case studies, the thing with delirium versus a seizure, right? So it causes a lot of weird symptoms that really knocks you off your feet, besides the pain, of course, right? And this person has diabetes mellitus, which nothing heals good, and your immune system doesn't work when you have diabetes mellitus, especially if it's uncontrolled. Now, she can be taking insulin, but maybe it's uncontrolled. So I think it should say uncontrolled here, right? She has a very high white blood cell count. So in our case studies, of course, I'll give you the normals, right? But this should be 10,000 max 10,000. 6,000 would be better, or 6 times 10 to the third. Pyuria is white blood cells in the urine, right? Casts are groups of white blood cells in the urine. And hematuria is blood in the urine, right? She was given antibiotics, but it was too late, because who knows? Either the bacteria, which could have been E. coli, but in this case it is E. coli, but it might not have been E. coli for this person. So the bacteria could be resistant, like a MRSA, a mitomycin resistant antigen that's resistant to the antibiotic. So it didn't work. So sepsis is when this bacteria gets into the rest of the body, right? It's a blood infection now. It's not just a pyelonephritis. So I guess this story doesn't end so good, because I think she dies, right? She died. That's the end of that case study. All right, now it's a forensic study, right? Because she didn't make it, because she had sepsis, and the antibiotics could not control the bacteria, ravishing all her organs. So this could be histology of that person, and this could be the gross anatomy post-mortem with abscesses that way. You see, that's not normal, right? Many abscesses, many areas of pus and inflammation. More of the same. Chronic now. Chronic pyelonephritis, massive amounts. So this is what happens when an acute UTI or acute pyelonephritis goes untreated. And it's going to affect the morphology of the kidney, ultimately, right? Here's the normal, massive amounts of PMNs, neutrophils. And you have some normal glomerulus, but this is glomerulosclerosis. You see that? So she may have had a problem, or he may have had a problem with the kidney to begin with, or high blood pressure, chronic UTIs left untreated, or diabetes on top of it. So all those comorbidities or risk factors for this kind of condition. And if you go back, when you're going over this PowerPoint, this will explain what we just did. Okay, calculi is the stones that you hear about, like calcium oxalate is the most common. Renal calculi. So renal calculi is a kidney stone. I put it together. Calculus is a stone. Usually it starts out in the nephron and the renal pelvis and bladder as just crystals, right? Calcium oxalate crystals that you can see microscopically in somebody's urine. But if you increase the acid in the urine, and normally the urine should be between 4.5 and 8, but if it maintains a low pH for a long time, the urine is going to constantly be concentrated with crystals like calcium oxalate, and there's other crystals like uric acid crystals and triphosphate crystals that can form stones. But the most common is the calcium oxalate, right? And this is extremely painful because it's obstructive, right? This is obstructing a ureter. Could cause a pain in the bladder, right? And it can be so large, it can obstruct the renal pelvis. So you're going to have pain, obviously. You're going to have a lot of pain with this because it's not always this smooth. It could be shards of crystals on there. So this is a stone, though. This is beyond the crystals. Now, this crystals can float apart. But this is if you crystallize everything together into a stone called the calculi. So you're going to have pain in the flank for sure. You're going to have blood in your urine because of the destruction. You can even have epithelial tissue in your urine because of the destruction of these conduits, these tubes. Colic pain is pain that kind of waxes and wanes. So waxes means it comes on really strong and then it kind of dissipates a bit or abates. That means wanes and then it comes back. Because there's peristalsis going on in here. Your kidneys are trying to release the urine that's building up behind this obstruction. So that adds a whole nother problem to the kidney. And of course, if this is left untreated, you're going to have a problem, right? So I don't think you're going to pass something this big. It's possible to get that all the way out of the urethra, through the bladder and out the urethra. But a lot of times they have to do surgery or do lithotripsy, which is putting you underwater and just blasting you with ultrasound so that stone breaks up, that calcium breaks up if it's possible. Sometimes it works and sometimes medication helps along the way. This, of course, is a circus view of kidney stones, renal calculi, calcium oxalate, post-mortem. I mean, that's crazy how much. This is more what they're like. If you could pass them, you could. Sometimes they have you pee into a strainer while you're in the hospital dealing with the pain. And, they'll take a look at what's exactly in these stones to see what the problem is. Is it a uric acid problem or too much calcium, which is more typical. Calcium, dehydration, sometimes just bad luck, sometimes genetic problem with concentrating urine, right? Low ADH, drugs that you take, right? And your diet, of course, high in those high salty foods, nitrates, certain alcohol, use of alcohol, which dehydrates you, can cause an increase in crystals, which ultimately will give you the calculi. So I guess you take these home in a little jar after they get rid of them, or you pass them, so they say. And that's normal, right? That's normal. I think we know the difference between that normal kidney. We showed you the normal before. You have this picture on the other PowerPoint with all the parts, like where the urine is, the minor calyces and the major calyces, renal pelvis, ureter. So this is a post-renal problem, kidney stones, right? Post-renal. The problem is not the kidney so much as coming from the outside of the nephron. Now, acute tubular necrosis, now we're talking about the tubules like the PCT, DCT, and the loop of Henle. So this, again, bad luck sometimes, but most of the time, the destruction or death of the tissue, that's what necrosis means, could be something to do with a medication that you're taking. It's nephrotoxic. Like, you know, it might be a little extreme, but something like an Advil, or not Advil, but Tylenol, acetaminophen, has to be filtered out. You know, that's a synthetic medication that has to be filtered out. But if you take too much of one thing, or you mix it with alcohol, it may start to tax your kidney and you'll get destruction of the tubules. Of course, that's a little dramatic, but think of somebody getting chemotherapy or somebody abusing drugs or taking a drug that has this as a side effect, kidney problems. And on top of it, you may have another comorbidity, or you may have a problem with your kidneys, like glomerulonephritis or history of pyelonephritis. So this just adds to the problem by introducing these kind of things. And ongoing infection, pyelonephritis, could also cause tubular necrosis because, again, all that inflammation is going to start to destroy the tissue. So that's acute tubular necrosis. So look at the normal. Again, this is a PCT here. This is a DCT. Look at the lumens. The lumen is more pinkish in the PCT because it has more solute. And the nice clear basement membrane are holding together these simple cuboidal cells that you know are for secretion and absorption. So this is kind of ruffled borders of that lumen, of that tubule. Not that easy to see, right? Especially here. This is a good example of some acute tubular necrosis. And it can be reversible in the tubules, right? That can be reversible. It depends on how far this goes untreated or whatever's causing the acute tubular necrosis, how long that insult continues. I think this is a little better picture of acute tubular necrosis. You can see how those cells are kind of obliterated. Look at the normal glomerulus though, right? So the blood vessels are okay, but the problem's in the urine, or the filtrate, I should say, I'm sorry. This is normal. Top left is normal, like we saw before. Cancer of the kidney. There can be primary cancers of the kidney. This is, of course, post-mortem of a huge carcinoma, primary carcinoma of the kidney cells, the parenchyma, the nephron, and the cells of the kidney are mutating to cause this big cystic tumor. Now, how do you know it's not just a normal cyst? But look at the size of this thing. And the tissue is all necrotic. All this parenchyma has become necrotic because not because of a fluid-filled cyst, but because of cancer cells, immature mutated cells that are destroying the parenchyma. This is normal, right? This is normal. Big difference, right? So that's primary carcinoma of the kidney. So you can see, again, this was that normal we saw, which is a very young kidney. This is a normal cyst. This is a young fetal, maybe even kidney. Because most kidneys don't have these lobulations. Because your kidney has like maybe 6 to 8 lobes as an adult, you know, with all the medulla and the around surrounded by the cortex. So it doesn't look like this in an adult, it's smoother. But the point is, this tissue is gone. It's completely non-functional. So whenever that happens to a kidney, no matter what the cause, in this case it is carcinoma, you're not going to have the use of that kidney. So you may need dialysis, right, which you may have talked about in lecture, about how you use a machine to filter your blood and return those electrolytes and glucose and amino acids back into your blood to fuel your cells, of course, and run your metabolic cycles. Kidney transplant is another answer. If you can use one kidney, you can get 60% or so of your kidney function out of one kidney, but of course that taxes the kidney. So it depends on what the cause of the kidney disease, the glomerulosclerosis or ongoing glomerulonephritis or cancer. They could transplant the kidney. This is really hard to see. This is carcinoma, which is just immature cells. I don't know how you could really tell the difference between this and pyelonephritis chronic. Right? I don't know what to tell you. Because the only normal piece of tissue I see is here in this. And this is all cancer cells in here. I can't even see anything. I can't see any glomeruli. Maybe I'd be reaching to see something here. Again, these are cancer cells though. This is a little easier because at least you have some idea that this is the cortex. You can see normal glomeruli. I don't really see great tubules, but I see some. And over here, I see nothing, you know, really nothing. So that is carcinoma, right? Of the primary carcinoma, most likely. Cancer cells all in here on your left side. These are cancer cells. And this is more normal. Better on that side. So you could have metastasis. How do I know that? I don't. But if you see this, and these don't look like cysts, obviously, this is necrotic tissue. Again, to find out if it's metastasis rather than primary carcinoma, you would have to do the genetics of the cells that are in these tumors to see where they would come from. You know, what part of the body did this cancer come into the blood and reach the kidney? Was it a prostate in a male, or ovary, or a uterus in the female, cervix, breast, right? That breast cancer, pancreatic cancer that started someplace and made its way to the kidney to cause this metastatic. This is would really be a problem. But obviously, if this is metastatic, you're going to have other problems as well. So for this slideshow, this is what a metastatic carcinoma would look like. So kind of know the difference like you did with the lung, or a primary carcinoma like squamous cell in the lung versus metastasis. So now it's primary carcinoma of the kidney, the parenchyma of the nephrons, versus metastatic carcinoma, visually. So you probably did this in lecture, acute renal failure. Now, it could be pre-renal or intra-renal or post-renal, right? So pre-renal has more to do with your cardiac output or a severe drop in blood pressure, because as you know, the kidney is very sensitive to low blood volume, low sodium, low pressure in the afferent arteriole. So it really creates a lot of enzymatic and hormonal release to speed things up. So that is going to cause kidney failure if you don't have the blood supply to that organ. You know, right-sided, left-sided heart failure as well. All right. Intrarenal is something like glomerulonephritis or possible cancer or glomerulosclerosis, anything that's in the renal, in the kidney or nephron. So that's why it's intrarenal, not just renal, intrarenal. So it could also have an acute renal failure due to post-renal problems like obstruction, like a kidney stone, a calcium oxalate calculi, renal calculi, spasms in the ureters. In men, the prostate gland it actually surrounds the membranous, or the prostatic urethra. So your men's urethra goes right through the prostate gland. So you could have a BPH, which is benign prostatic hypertrophy, or prostate cancer, which enlarges the prostate. So that's going to cause an obstruction. So the obstruction could be here too. You can have that, like you saw before, the kidney stone. So that's going to cause a major backflow and tax the kidney and the glomerulus and the tubules, and cause all those things to happen, like glomerulosclerosis, acute tubular necrosis, leads to kidney failure, in this case, acute kidney failure. You can't filter your blood anymore. You can't reabsorb your nutrients anymore because of these three basic causes of renal failure. ARF, acute renal failure. This is a good picture too. Just shows you the difference, the pre-renal, intrinsic, within the nephrons, which are, there's a million nephrons to one kidney. you can't really see it. So again, physiology, the blood test, the urinalysis, of course, which you could see, hematuria, which is blood in the urine. Glucoseuria is glucose in the urine. Anything with urea at the end, right? Urea. Ketonuria, ketones from fat metabolism. Albuminuria, which is the albumin or protein in your blood, like proteinuria. So that's all pathological and could be a sign, one way of seeing renal dysfunction and possibly acute renal failure. And the post-renal failure has to do with an obstruction, maybe in the urine trails, right? It's somewhere between the minor calyx and all the way down to the ureter or bladder even. End-stage renal disease, so now the kidney becomes completely dysfunctional. There's no parenchyma left to use. There's no more functional unit. The nephrons are not working. It's complete, massive. This is not just glomerulonephritis. This is end-stage renal disease. So now we have to decide whether there's going to be a transplant or, especially if dialysis is not working. Because medication is not going to help here. So hopefully this is just one kidney and you can do a transplant. If not, you're going to be on dialysis forever if you're in end-stage renal disease. So of course, this is too late in the post-mortem with the kidneys showing, unless they took this kidney out and transplanted it. So end-stage renal disease, massive amounts of glomerulosclerosis and glomerulonephritis. And what's worse, you can get more chronic pyelonephritis. Okay, so about a thickening of the artery basement membranes, which is glomerulosclerosis, which you saw. You should know what that looks like. This is just post-mortem, of course, of a transplanted kidney. They kind of, they can leave the kidney in that, like say this is the kidney that is not functioning. They'll just leave it in there. The native kidney, they may just leave it in there. It depends on the person. They may take it out. And then they just hook up another kidney to the bladder, right? Of course, it's not down here, like in your abdomen. It's or lower in your abdomen, in your leg. It's up and here. This is put on a table, right? So this is a transplanted kidney with that conduit of ureter to release the urine into there. So they hook the blood supply up through surgery and through the abdominal aorta and on both sides, of course, hopefully this kidney may be working okay. Right? So it's just showing an extra kidney in there. So, but like I said, sometimes they just leave the native kidney in the body. I think because it'd be too taxing to take it out. So they just disconnect it and, it won't become infected if there's no blood supply, no true blood supply, right? So I guess it depends on the age of the person, the health of the person. Right? I would imagine in a young person it's coming out though. Like a really young person, somebody in their 30s, or something like that, they would probably take it out. But an older person, not so much, because it might be more of a problem. And that's it.